My name is Doreen Chung, and I am an FPMRS urologist at Columbia University, New York. Today I'm presenting safety of transvaginal mesh versus native tissue repair for the treatment of pelvic organ prolapse, a 36-month prospective study. I'm presenting these results to you on behalf of my co-authors, as well as other investigators and collaborators who worked on this research. This study was conducted at 27 different sites across the United States between 2013 and 2020. All the authors or their institutions received some type of compensation for the work that they did for this industry-funded, FDA-mandated 522 study. Transvaginal mesh was first used to augment the repair of pelvic organ prolapse in 2005. Previous studies have suggested higher complication rates for transvaginal mesh compared to native tissue repair. However, meshes used in previous trials were higher volume than the newer products available. Compared with other marketed devices, the Uphold LITE vaginal mesh was designed to strategically place a minimal amounts of mesh to augment prolapse repairs in the anterior and apical compartments. It is placed using a single vaginal incision and attached to the sacrospinous ligaments bilaterally. Due to concerns of safety and effectiveness, in January 2012, the FDA ordered all manufacturers of vaginal mesh products to perform post-market surveillance studies under Section 522 of the Food, Drugs, and Cosmetic Acts. In response to that order, this prospective non-randomized parallel cohort multicenter study was completed. Boston Scientific was the sponsor of the study, but the methods I will describe represent a negotiated agreement between Boston Scientific and the FDA. It was also conducted in partnership with OGS. Subjects in the study received either the Uphold LITE or underwent traditional native tissue repair with urosacral ligament suspension or sacrospinous ligament fixation with or without colporphy. The native tissue repair arm included a combination of enrolled subjects as well as subjects from the OGS Pelvic Floor Disorders Registry. While the study assessed effectiveness and safety, I'm going to report today on the safety endpoints. The primary safety endpoint was to compare rates of serious device or serious procedure-related adverse events. Secondary safety endpoints were mesh and procedure-related complications between baseline and 36 months post-procedure. Non-inferiority was specified at 10%. Because this is an observational study, propensity scoring was used to account for differences in baseline characteristics between the groups. Factors that may have affected study outcomes were identified based on recommendations of the FDA, and the analysis was performed by independent statisticians who are blinded to all clinical outcomes. Results. In this study, transvaginal mesh was as safe as native tissue repair in the treatment of anterior and/or apical vaginal prolapse with respect to the serious adverse event rate at 36 months. As you will see in this table, in the intent to treat a cohort, 3% of transvaginal mesh subjects and 2.7% of native tissue repair subjects developed serious adverse events within 36 months post-index procedure. The upper bound of the propensity score adjusted confidence interval was less than 10%, and non-inferiority of transvaginal mesh to native tissue repair was demonstrated. This table presents overall device-related and/or procedure-related adverse events at 36 months in the intent to treat subjects. Within 36 months, the overall adverse event rates were similar between the transvaginal mesh and native tissue repair arms, 35% in the mesh subjects and 46% in native tissue subjects. Most of the device-related and procedure-related adverse events occurred within the first 6 months following surgery. The incidence of mesh exposure was 1.3% at 6 months, 2.2% at 12 months, and 4.9% at 36 months. 5 mesh exposure patients had surgical intervention, 3 had office-based procedures, and 3 had no intervention. The rate of office-based intervention for complications was similar between the study arms, 5.8% in the transvaginal mesh subjects and 8.2% in the native tissue repair subjects. 7 native tissue repair patients had in-office intervention for suture exposure. 4 transvaginal mesh patients had in-office treatment of mesh exposure, and 3 patients, 2 mesh and 1 native tissue, had pudendal nerve block for neuralgia. The surgical intervention rate for complications was not significantly different between the groups. with 8.9% for transvaginal mesh compared with 7% for native tissue repair. The rates of surgical and office-based interventions for complications were similar between the transvaginal mesh and native tissue repair groups. The mesh exposure rate at 3 years post-surgery was 4.9%, which is much lower than the 12% rate reported in a 2016 Cochrane review with 1 to 3 years of follow-up. In a prospective study comparing transvaginal anterior mesh to native tissue repair, Ayman et al. Reported a rate of 3% for vaginal wound revision at 12 months and lower surgical intervention rates in the native tissue arm. In contrast to our study, Ayman did not report office interventions. In our study, the rate of requiring surgical or office-based intervention for mesh extrusion was 3.2% at 36 months. Of note, transvaginal mesh is no longer approved for use in pelvic organ prolapse surgery following an order by the FDA to all transvaginal mesh manufacturers in April of 2019. In this study, no significant difference in complications or adverse events was noted between the transvaginal mesh and native tissue repair groups, suggesting that these procedures have similar safety profiles for the repair of apical and/or anterior compartment prolapse. Before permanently removing transvaginal mesh from the armamentarium for pelvic organ prolapse surgery, we feel that more comparative studies are needed. I would like to acknowledge my co-authors on the submission and thank all who worked on this important clinical trial. Finally, here are the references for this presentation. Thank you for your time and attention.